All right, look, I think we'll get going. Thanks everybody for registering and attending today Dr. Kaplan's seminar on evaluating stress cases. He has a very long and distinguished career in not only clinical psychiatry, but also as a medico-legal writer. Now, if it's just okay with everybody, I'm also going to introduce Lachlan White, who's going to spend 3 minutes of your time quickly going over a new business that MAG is associated with now. We have sold our platform to a company called Insurance and Compensation Services, who are putting our platform on steroids and doing some AI work around claims and loss of revenue for insurers. It's mostly around, well, I'll let Lockie talk about it. So Lockie, over to you very quickly.
Thanks, Mike. If you could just enable screen sharing, please. You've disabled that for the meeting.
Yeah, that's right. And we're on Zoom now, aren't we? Which is why I couldn't go and find where to share my screen and had to pivot the conversation quickly, make it sound like I knew something about what I was talking about. Because Zoom is down the bottom and Teams are up the top. Thanks, Locke.
Thanks, everyone. I understand that everyone's here to see Dr. Kaplan, so I won't take up too much of your time. So Insurance and Compensation Services, which is the business that now works with is using the MAG platform, is selling the MAG platform. I guess we deliver a range of software solutions to the insurance and personal industry. We have the flagship, what's called the ICS Connect platform, and that's the workflow management solution that is really available for all personal injury stakeholders. As well, ICS has developed a range of additional software solutions. These include some telehealth solutions, as Mark was saying, an AI claims management solution. We've got client sector specific platforms and some integrated data and analytics tools which can assist in the efficiencies and reduction of that claims leakage where required. One of the client's sector-specific platforms we've got, it's called ICS Law Connect, and it's a fully customizable platform for law firms, which assists them in their information gathering processes. And this includes modular service-based offerings, jurisdiction-specific communications and reminders. We've got API integrations with government portals for evidence retrieval, external stakeholder logins to assist law firms in their retrieval of evidence and engagement with their injured client. ICS has also developed a version of the platform called Insurer Connect. That's our class-leading insurance software solution, which improves return to work outcomes and increases work efficiencies. This includes a panel management functionality for specialists, workflow and correspondence management, integrated telehealth solutions, and a range of features and functionality to assist insurers in their return to work goals. And the final specific platform that ICS has developed or version is called GovConnect, and it's designed to allow government bodies at all levels to manage compensation claims at an excellent service standard. So it's a fully compliant document exchange platform with worker communication solutions to improve those return to work outcomes, and we've got integrated data and analytics tools to assist government bodies in their compensation claims. On another level, we have additional ICS solutions, which include, we've got some AI tools, some work around claims leakage and financial calculations. We've got a couple of open source data analysis projects, which can assist in terms of your claims management efficiencies. And then we've got integrated telehealth solutions, which can be added onto different platforms as required. So if any of these products do sound interesting to you, please get in touch with Insurance and Compensation Services to see how we can assist you in your software needs. With that said, I'll pass back over to Mark to introduce Dr. Kaplan.
Thanks, Locke. Yeah, we've got some ICS has got some really interesting projects going. Now, I'm just going to do a quick screen share for my introduction to Dr. Kaplan. Because I just want you to know about his background and the work that he's done and the books that he's written and I hope I'm doing this properly, because he really is, and I'm sure he doesn't like people talking about him in third person whilst he's in front of us, but he's really an amazing man, amazing human being. Not only has he achieved all that you possibly can in his area in terms of the academic achievements, but if you look down, and he's done this all from Wollongong, which is probably an achievement itself. Sorry for that little cheap shot, Robert, but I know you get up to Sydney a lot. I just want to go down to the books that he's written and the topics that he's covered over the years. What Was Wrong with Hitler, The Shocking Mr. Silver, Prelude to Breivik. These are just fascinating areas, and this goes to Robert's fascination with the human condition, which is why I think his medico-legal reports are industry leading. And I would encourage you to have a read of his books, because if you're looking in to find out a little bit about the mind of Dr. Kaplan, I reckon they'd be right in those books. Although he'd say that he's exploring the minds of other people, I'm sure the way that he writes it would tell us a lot about him, which is why I always love introducing Robert, because he's always willing to share his knowledge, and it's very well supported with his studies, and I think just the way you write and present the facts of the matter that you're investigating are really just exceptional, Robert. So I appreciate the time you've taken today to continue to contribute to the education of everybody in the personal injury industry. And over to you. Now, I know we don't have a slideshow for today at the moment, although this is being recorded, and with your permission, we will distribute it at the end of today's seminar. But if it's okay with you, Robert, I'm just going to leave your website up as you talk to everybody, and then after you've done your own introduction and beginning, then I'll take the website. I'll take the website down, if that's okay with you.
Thanks, Mark. As long as I can see myself on the screen, I'm happy.
And is that, you can see yourself now?
No. Now, that's fine.
Okay. All right. We'll go back to the setup. All right. All
okay.
Good.
Well, good morning, everybody. Let me explain my location. My internet broke down, so I've come down to a friend's house, and there's a very friendly little dog that's occasionally prone to yapping. So forgive me if there are any interruptions. So that's the setting for this talk. And firstly, I want to point out that the issue of stress claims is really a two-part series. And I covered adjustment disorders and related issues in the first talk. So today I'm going to focus mostly on what I call the big one, post-traumatic stress disorder, as we all know, PTSD. And even in that statement, the initials PTSD have huge impact culturally, socially on the internet. It's become a cultural feature. And that, of course, plays a big part in the way it presents. So I want to start off by reading two very interesting quotations. The old timer shows the new guy how to work the system. Before you go in for evaluation, don't shave for 3 or 4 days. Wear old clothes, some unit patches, an old beret. Study the symptoms of PTSD. That's the first quote. And the second one, any unit of classification that simultaneously encompasses the experience of surviving Auschwitz and that of being told rude jokes at work must be, by any reasonable lay standard, a patent absurdity. The first statement comes from a veterans group in America, and the second one comes from a leading writer and critic of the PTSD explosion, Paul McHugh. So let's just look at what PTSD is really meant to consist of. Everybody knows it's got to be a severe, life-threatening stressor outside the normal range of human experience. So this wipes out a lot of day-to-day events, and also it wipes out things like medical events. Having a baby, having a tooth pulled, these are not events that count. And in the classification system, these are what is known as criterion A. In the DSM-5 classification, you've got to meet criterion A first and then have a range of symptoms. Now, typical symptoms are hypervigilance, arousal, emotional numbing, phobic avoidance, flashbacks, anxiety, depression, and nightmares. And I'm going to say something I'll repeat through the talk. There is currently a worldwide pseudo-epidemic of PTSD for a range of reasons. Number one is the media publicity, social issues, it's what we can call the victim culture, and compensation or financial reasons. It can be, in many situations, extremely lucrative to have a claim accepted for PTSD. The critical feature of PTSD, unlike any other psychiatric condition except adjustment disorder, is that there's got to be an external event, and it's got to constitute criterion A, a traumatic event. And now we get into some very muddy quicksands, because one man's trauma is another man's malingering, if you know what I'm trying to say. There's just such variance in what people consider traumatic. In order to understand PTSD as it is now, we've got to just look quickly at the history. PTSD goes back as far as the human condition. There's good descriptions in the Bible. For example, King Saul, after a particularly heavy battle. The Vikings, you could get a condition called berserk or berserk if you're exposed to too much battle. Napoleon's soldiers were exposed to cannon fire and would develop symptoms. And more recently, starting from the American Civil War, you got soldier's heart, World War I, you got shell shock, you got war neurosis. By World War II, they were changing the names to combat exhaustion or battle fatigue. Later, you got prisoner of war syndrome, which really overlapped a lot with people who'd come out of concentration camps. And then, critically, the post-Vietnam syndrome. And we will look at why that is so critical. So just let me read that definition again, because people really need to have a clear view about this. It must be actual or threatened death or serious injury, or of an exceptionally threatening or catastrophic nature, likely to cause pervasive distress in almost anyone. And here you get to the subjective element. As I've said, medical issues like having a tooth extracted, a difficult baby delivery do not count. And for the same reason, seeing as we're in an Australia-based anyway epidemic in claims of bullying, being the recipient of bad arguments or sexual jokes at work. What have we learned from the history of PTSD? The first thing is, remember all the names I gave to it. The symptoms of PTSD vary with time, place, culture, and social circumstances. So prevailing attitudes are enormously important in shaping how people perceive and present with the diagnosis. Again, we get back to the victim culture. Now, the way PTSD presents in Australian forensic settings goes back to the Americans, namely the Vietnam Veterans Lobby. They described a condition seen in Vietnam veterans where soldiers would come back, they would not be able to settle, they'd have poor relationships, poor working, abuse of drugs and alcohol, violent outbursts, and even criminal behavior. And this was the so-called Vietnam Veterans Syndrome. What they did was it became a political issue. And this fed through to the DSM, the Diagnostic and Statistical Manual, in 1980. Think about it, we've got a psychiatric condition that's been well described for 150 years, but it's now been taken over by a committee making a political decision. And that is how the DSM and how the current modality that in every legal setting is defined. It's very, very poor, and it's very, very controversial. Let's just go back to the critical issue. What actually did happen to soldiers in Vietnam? The interesting part is diagnosed on the spot, meaning diagnoses made of soldiers fighting in Vietnam was very low. It was approximately 10%. And that's not a bad figure for an army fighting a difficult and losing war. What is interesting is once the war is over, the more time that passed after the war, the more the claims increased. And people started saying, what's going on? You'd expect the people on the spot having the injury, having the traumas, to put it in the most, but this was completely different. And they started looking more critically at this. For example, they looked at the incidence of flashbacks and nightmares in citizens and combat veterans. It varies from 10% to 70%. The rate of PTSD following exposure to earthquakes varies from, wait for it, 3% to 87%. All that tells you is that people have got such different perceptions, ways of diagnosing and ways of presenting. What happens in motor accidents? It's a reliable figure that 15 to 30% have PTSD, and one that is a genuine trauma, 80% of rape victims. Now, we saw a very interesting thing happen with the 9/11 bombings, if you want to call it that, in New York. It was assumed that every person in New York, in fact, if not in the rest of America, would get PTSD simply by being there and watching the whole thing. Therapists ascended in their thousands on New York and found there was no work for them. In fact, what was called virtual or vicarious PTSD was almost non-existent. Now, there's a couple of conclusions you can draw from that. The 9/11 bombings were terrible, but they unified America. This was not an attack on a particular group of people or place. It was on the whole of America, and it was the same issue that explains why in wartime suicide rates go down in the civilian population. So what they did was they did a lot of studies, and somebody came up with this rather cute line. If people watching 9/11 bombings on TV get it, it must be described as PTSD of the virtual kind. In other words, it's not PTSD. One of the problems that spun off from DSM-3, DSM-4, and DSM-5 is the so-called tick box approach. In order to try and classify psychiatric illnesses systematically, DSM puts symptoms down in a list. You have so many to make the diagnosis, and you also have exclusionary ones. And this has led to a serious problem of assessment. There are plenty of people in all professions who simply sit there with someone and go, have you got this? Have you got that? Tick, tick, tick. You've met the criteria. I mean, this is psychological and psychiatric assessment at its worst. And we'll talk about this if I've got some time, because simply having let's say, nightmares or flashbacks is actually meaningless, because you can have these things in so many different conditions. So what you've got to do is not just say yes or no, you've got to go in and investigate. Now, in my other life, I used to work in a sleep clinic. So it's a part of my examination to do a proper sleep history, something unfortunately that's not done frequently enough. And when you find people claiming to have PTSD with nightmares, you often find that they're not describing what you should have. The nightmare a person with PTSD has is frightening, it's awful, but it's context specific. That means it's about the situation you were in, the trauma. What people often describe is quite unrelated. They don't make a distinction between a nightmare and a dream. And of course, you can have bad dreams for any reason. And they often have episodes of something called sleep paralysis. Now, sleep paralysis is very frightening. It occurs in 40% of the population, but it's not a feature of PTSD. So you see what I mean in that by just going on yes, no, tick box approach, you can get very lost and almost certainly end up with an incorrect diagnosis. What we have, another point about PTSD, we have in London Professor Simon Wesseley and Edgar Jones, and they did historical studies of case files going back to the Anglo-Boer War in 1901, all the way through to the Gulf War. And they came up with a number of interesting findings. The first one is that each war had different symptoms. And secondly, where you look at cases where there's no doubt about the traumatic event and an illness following it, is how often they have widespread anxiety and or depression rather than your classical PTSD, nightmares, flashbacks, numbness, hypervigilance. And that's a very important thing to remember. The other thing, going back to the Vietnam veterans, as I said, there was a lot of concern about why are we getting more and more claims. So they did something that appeals to my writer's heart greatly. They sent in the historians. And the historians looked through the files critically. And what they found is that a lot of the people making claims, number one, if they were in Vietnam, they were never exposed to combat. I mean, every army, for every soldier in the front, has 10 people behind him in administrative roles. And these were people in those roles. They even found a number of people had not even gone to Vietnam. They'd simply served in the army at the same time. So you see how this works, that when you examine it critically, you find people are hopping on the bandwagon for which there's no basis. Now, what are the critical features of claims of PTSD that must be questioned and may well be non-existent? The first one, and anyone working in the field will tell you, and this is in any country where people make claims, which is just about everywhere, is people in institutional services. Now, that's not a good word, but it's the only one I can think of. By that, I mean the military, the police, the prison service, the ambulances to some extent, and the fire brigade. They are the ones who have the PTSD culture most rigorously. It's reinforced and enhanced by their colleagues, and there's a real culture there. The other thing is that often, I can't say exclusively, but often the particular institutional group is rather old-fashioned in its structure, and it has old-fashioned industrial norms, and that plays a part in it. Now, the second thing I've already talked about, this has got a lovely name, comes from Richard McNally, the guy who investigated the Vietnam veterans. It's called bracket creep. Now, bracket creep refers to the fact that what we started off with, somebody who's been in a battle, somebody who's had a terrible car accident, somebody who's been raped. Those no one would argue with as traumatic events. What you start seeing is that it creeps higher and higher to the point of any disturbing event in your working life, and here's the critical part, that is claimable, suddenly becomes a traumatic event. Now, you might say, well, people can come ahead and say these things. Don't they get mopped up at the assessments? And the answer is no. They don't, because there are a number of people who assess, social workers, psychologists, psychiatrists, who are deeply sympathetic to these assessments, and they facilitate bracket creep. So that's an important issue in claims. The third thing is called the stress inoculation theory. Now, the stress inoculation theory is in some ways almost amusing, because it's based on the prevailing view in the public, let's call it the cultural view. The more you're exposed to traumatic events, the more likely you are to get PTSD. And if you talk to people who are using this rationale, they'll often say, Doc, it's like the pot. It gets, when you boil it, it boils over on the 20th traumatic event. What's the problem with that? Well, it goes back to the problem of 100 years of scientific research. How do we predict when we send people into a traumatic situation, meaning battle, who is going to get PTSD? And you cannot believe how many studies have been done and how many attempts in different places and ways have been done. It is impossible to predict, if you put 100 people in the same defined traumatic situation, who will get PTSD. We've looked at everything. Certainly their personality doesn't count. What has been shown, the only factor, is a past history of psychiatric illness, and perhaps glued onto it is a family history of psychiatric illness. Other than that, there's no way of predicting it. So when somebody says, I've got 20 traumatic events, that by definition means I've got PTSD, it does not. It is simply their perspective on how they got PTSD. And we'll come back to this. So remember I said the findings of people like Simon Wesseley, that when people are in genuine traumatic events, they're more likely to get anxiety or depression in some shape than the defined PTSD. And there's a whole list of conditions that often present this way: adjustment disorder, dissociative disorder, dysthymia, depression, mania, personality disorders, psychotic disorders, and of course, all kinds of drug, alcohol abuse and gambling. So when you look at somebody who says they've got PTSD, you've got to have a differential, meaning you've got to consider as alternatives these diagnoses and a couple of other ones. And I'm saying this not because this is a list in the articles I've considered, but it's turned up in my cases. Bereavement is one, bipolar disorder, obsessive compulsive disorder. It's astonishing how people turn up with the classic signs of OCD, and it's all attributed to PTSD. Another case that I saw was somebody who kept having visual hallucinations, and they had nothing to do with her work as a police officer. But what we found out is she'd had quite a severe head injury. And a typical response to a head injury, not PTSD, is visual hallucinations. So she was sent off to the neurologists and neurosurgeons very quickly. So those are some of the issues you consider. Now, let me go back to the way in which so many people, particularly in the army, the police, the corrective services, and the fire brigade present. DOPT, delayed onset post-traumatic stress. Now, firstly, it goes against the clinical experience and logic. You would expect, and it's correct, that people are at their most disturbed and most upset in the time immediately after the traumatic event. And it's supposed to, linger, but to some extent show some settling over time. DOPT, on the other hand, is defined as PTSD 6 months minimum after the event. And this has been challenged time and time again. If you look at retrospective reports, they just don't confirm this. If you look at some cases and you take a careful history, what you see is not delayed onset, but delayed presentation. In other words, they had symptoms of some kind, perhaps not told, perhaps not very big, but they were there. And that's different. So this is where the stress inoculation theory comes in. And it comes to the assessor in the form of a trauma list. And the trauma list is seen in many people of these cultures applying for PTSD acceptance as almost your ticket of entry. And people will come in with these lists, which they'll give you, where they've carefully written out, let's say it's a police officer, every event that they would consider frightening, dangerous, traumatic. Well, this is part of their work. It can cause trauma, but it doesn't have to. And it goes back to this belief of, I just need a certain number of traumas, and then I've got the ticket. Now, so a lot of good studies have said, be very careful accepting these accounts. What we have is, in fact, one of the few worldwide studies has been done by Richard Bryant in Australia at the University of New South Wales. And he examined motor accidents. And he only found 5 cases of delayed onset PTSD in 200 motor accidents. That is good. Those are good statistics. Those are sufficient numbers. So Richard Bryant today will say maybe delayed onset is relatively uncommon and at most say 8 to 12%. And I think he's being very generous. So there's something to remember about this. This trauma list is a critical event. What you also see, and is often neglected, in fact, the trauma list is intended to deflect your attention from this, is why the person leaves work. And this is often critical because they didn't leave work because they had another trauma. They left work because they had an argument, they got demoted, they got put on a performance review, they got transferred where they didn't want to go. Something happened in the workplace. And what's often a giveaway sign when you examine them is that they will tell you their traumas. They'll read off the list completely mechanically, stereotyped. Then you ask them, look, what happened when you left work? Suddenly, you see real emotion. They're angry, they're upset, they're really furious. And it's quite clear this is the incident that is causing their symptomatology. And this plays a part in the whole issue of misdiagnosis. And it also plays a part in another set of initials, not as well known as PTSD, but let me get it right, DEPD. And I'll tell you what that is in a minute. The other thing to notice with claims that are questionable for PTSD is what's known as modality swap. Now, what's modality swap? You put in a claim for a back injury, a physical injury, and it either gets knocked back or it looks like it's not going to get very far. So then you immediately say, well, I've got PTSD from the event that caused the back injury. And you can see this is purely an ambit claim and a rationalization. Now, what I've done is compile a case vignette, which is so typical. Obviously, it represents my findings from a number of cases. 42-year-old police officer does general duties for 12 years at various locations, applies to become a detective and very pleased to get that. 5 years before they present, they're put off work for 3 months on a back injury, which has a good but not complete recovery. As a result, they're on what's called light duties. They're not doing detective work where all the exciting things are happening. They're sitting in an office, they're shuffling files. This causes unhappiness, and then the officer is asked to transfer to a remote location or another one. Things start going downhill. Drinking, depression, marital problems, disillusionment. You can look at it, let's say, a year before it comes to a head, the marriage breaks down, and Detective X finally leaves work after a dispute with his sergeant over taking leave. Storms out of the office, and his doctor sends him to a psychologist who is known for treating police officers. And they also join a group of ex-police officers who've got PTSD, and they pick up these issues of trauma list, how you present, what are the features. So all of this is the background kind of difficult presentations you've got. And this is part of a bigger talk, but some of the things that I just want to stress. It's very important to look at their history before their problems started. You often pick up the real illness then. I mentioned physical illnesses. How did they leave work? How did they seek help? Are they getting treatment from the right people? It is no secret that, and it doesn't matter where you are or what country you are, there are doctors, psychologists, psychiatrists, and social workers who make a point of seeing institutional people like police officers, corrective services, and invariably support their claim with kind of stereotype tick box report where they just virtually change the name at the top. And always remember the issue of other diagnoses, adjustment disorder, particularly from workplace disputes, depression, which is very treatable, and conditions which are not related to work, social phobia or OCD, which again occur in constitutionally predisposed individuals, but are very treatable. Now, I just want to go through this working list. As I've said, in a checklist for, this is really looking at the end of the spectrum for people who are faking PTSD. Firstly, there's the appearance. Secondly, is their attitude at interview. They are sullen, resentful, they complain about having to go through it again, and they keep saying, hey, read my trauma list. When you ask them about specific symptoms, they're very reluctant to go into detail. They often say it's too difficult, too upsetting to describe the traumatic incident. Well, that I can sympathize with. But what you often find is they then proceed to describe the incidents in excruciating detail. The other feature is the use of jargon. Now, they won't say, listen, I'm terribly upset. I can't get on with anybody. I'm frightened. They'll say, oh, I'm hypervigilant with flashbacks and emotional numbing. Now, where do you learn this? You don't get a symptom that says, I'm emotionally numb. You actually become emotionally numb and you describe it as it's feeling. So the jargon is often a guide. And this, again, the stereotyped repeating of symptoms, the trauma list. And there's one very interesting symptom that may be exclusive to police, I'm not sure. It's somebody in an article listed it as a red flag syndrome. What they say is that they're so traumatized, they cannot even see a police officer in public. And in some of these cases where they've got a partner who is a police officer, the partner is not allowed to wear the uniform at home. I think you can draw your own conclusions about that symptom. Now, the last thing I want to talk about is PETD. This comes from a German Aussie Swiss psychiatrist, Michael Lindner. PETD stands for post-embitterment. No, post-traumatic embitterment disorder. And what he did was exactly what we've been talking about. He looked at a number of people, like army people, claiming PTSD, and realized that that wasn't the issue. It wasn't the traumatic events. It was the way they were treated at work. And this led to a sustained syndrome of resentment, bitterness, unhappiness, constant brooding, a sense of victimization. And I've heard him talk, and there are a lot of papers coming out on it, and I think it's going to get accepted before too long as a genuine condition. And what it will do is sweep away a lot of PTSD claims. And I suppose one of the last comments I can make before we start taking some questions is from a guy called Lise Haley, who did a lot of work on the thing. And his comment is, if mental disorders are listed on the New York Exchange, PTSD would be a growth stock to watch. Nancy Andreasen, a psychiatrist of considerable importance and president of the American Psychiatric Association, her quote, PTSD is the only condition people like to have. And I'll give you just an example. I saw a claimant and decided that they had an adjustment disorder. They were quite disabled. And as a result, they would get the same amount in their claim as if they had PTSD. I got back a huge complaint based on the fact that I had not validated their victim status, because adjustment disorder, of course, has no validity in the victim culture. Now, there's a lot of things to say about PTSD and all its manifestations, but I really think that's a good coverage. And I've skated over most important points. So, yeah, I'd like to take some questions.
I'm a gastroenterologist, and I've had occasional patients who describe symptoms of the irritable bowel syndrome, which they associate with a trauma, which may or may not fit PTSD. In your experience of genuine PTSD cases, have you found that they start exhibiting the symptoms of the irritable bowel syndrome, particularly diarrhea?
My answer is absolutely. Remember what I said about World War II. Most presentations of battle fatigue, as they called it, in World War II were gastrointestinal. So that you're absolutely spot on. And this is my point. It's not to deny that people have traumas. They do, and they're pretty awful sometimes. It's how they present, and they can often present in a somatic fashion.
Can you hear me?
Yes.
Oh, thanks, Robert. I enjoyed your talk. I'm a psychiatrist in Perth. Two questions.
Hello.
Hi. Two questions. One is, there are situations where people's workplace performance
Robert,
decline.
how are you?
Sorry, can you hear me?
Yes, you've just cut somebody off, Mark.
Oh, sorry. So there are situations, Robert, I think, where people at works, their occupational performance declines and they're more irritable and interpersonal issues develop, which may in fact be secondary to the PTSD rather than the actual reason for their departure at work. That's just one thing, the cause effect issue. I'd like your thoughts on that. And secondly, on a different issue, your thoughts about the PERS scale, because personally I think it's flawed and I don't think it captures pathology very effectively, but we're often asked to provide a PERS rating scale. And a lot of the lawyers are unclear about its use anyway, in terms of whether it measures impairment or disability, and also the issue of maximal medical improvement before you can provide that quantification. So I was just wondering if you had thoughts about those issues.
Yeah, look, let me, part one. Remember what I said, every case has to be assessed individually on its merits.
Sure.
If you start off with a tick box approach, oh, you've got PTSD and you just get put in this box, you get nowhere. Of course, people with PTSD can function badly at work and it can cause havoc. So if you assess properly, yes, you will get what you want. I couldn't agree with you more about the PIRS, WPI, or whatever acronym it's going under. It drives me nuts. I really think it's defective. And I struggle to see how it really assesses disability. So if you set up a website saying ban the PIRS, I'll sign.
Okay, thanks, Robert.
And the last thing is, my general view is we're trained as psychiatrists to assess people, psychologists. We're not trained to sit there and go with tick, tick, tick boxes and do questionnaires. So that's why we're here.
I agree. It's the craft. It's the craft and art of work, not some robotic process that a lot of psychology, many people do, and their results are really invalidated. Unfortunately, they have a lot of influence in some reports. They're not qualified. But yeah,
Yep.
Sure.
Thanks.
Yeah. Thanks, Robert.
Any other questions? I know there's some questions there just waiting to come out.
Oh my, there's a lot of people.
Got any more questions, Daddy?
Well, yeah, if I could, Robert, can you hear me?
Yeah.
Unfortunately, I missed your session on adjustment disorder. And I think that's often can be a problematic diagnostic label. I see many people where I think their response is disproportionate to the event, and so it would fit the old kind of paradigm of a neurotic state, which I know is not no longer evident, or it's recognised in the DSM. But I find that a difficult diagnosis because often it's a default diagnosis in somebody that's is symptomatic and not necessarily globally impaired, you know, interpersonally or occupationally or recreationally, but they do present with what I would consider a disproportionate response, which is a fairly wide, so it's a kind of low threshold for a diagnosis. And I do make the diagnosis, and sometimes with time it evolves into another condition, but it's been an area of concern because I think it's in many ways possibly a default diagnosis, and I'm not sure about the rigor, but I'm just interested in your thoughts about that.
Okay. Remember, adjustment disorder did not exist before 1980. It was invented by a committee to meet a statistical requirement for a wild card entry. Secondly, it's estimated that worldwide it is the commonest diagnosis in psychological psychiatric claim litigation.
Yep.
And its boundaries are jelly.
Yep.
Nobody's ever really defined it. Nobody's proven scientifically where it starts and where it stops. So yeah, I agree with you. it's each one you've got to use your judgment. And frankly, in the end, it is empirical.
Yes. Yeah. Okay. Thanks. That fits. Yeah.
If you send your email through, I'll send you some stuff on the adjustment disorder. I'm not quite sure how you loop up with the system.
Yeah. No, thanks, Robert. I'd like to do that. Yeah. Sounds
Okay.
good.
Mark.
Yeah. Any other questions?
Yeah.
Oh, actually, I have another one, seeing nobody's responded. Rob, are you still there? Yeah.
Yeah.
Robert, I see a lot of, I'm a child psychiatrist, so I see all ages. And I've been seeing a lot of victims of childhood, horrific childhood sexual abuse. And there's been some high profile ones in Perth. Now, I believe that complex PTSD is probably a valid diagnosis. I know the ICD-11 encapsulated in I think it was June 2018. Again, the criteria are loose, but a lot of the people, I think Judith Herman and some of the other researchers felt that it warranted a separate category because of the quantitative disturbance, and particularly in children with a history of significant chronic abuse, also obviously in Holocaust survivors, etc. But just your thoughts on that, on the category of complex PTSD, and whether you think it may get into the DSM-6. I know there was some speculation in 5. They called it DESNOS, or there was some other non-specific group, but ICD-11 has categorized. I'm just wondering about your thoughts on complex PTSD and where it fits in the spectrum.
Well, I have to tell you, in my peer review group, I have Carolyn Quadrio, who you may know of. And Carolyn, espouses complex PTSD because she sees the same cases you do. Yep. I can't predict the politics because it's not science, it's politics of DSM. But I think sooner or later it will be in. I can't tell you which category. But yeah, when you see young people brutally, revoltingly traumatized, I think it's very much a reality.
Yes, thanks, Robert. Yeah, that's my sense. And how one categorizes that, and as you say, it depends on committees. And I'm aware there's a fair bit of enmity between different groups and politics, and that makes the guys in Canberra look pretty tame, but that's a whole other issue.
Yeah.
Okay.
Right, Mark.
Yeah. Unless if Danny doesn't have any other questions, everybody, I'm sure there are other questions there. Maybe Danny's channeling the questions that other people have.
Well, my blood caffeine levels are starting to drop.
And thank you again for your time today, Robert. As part 2 of that series, with your permission, we'll distribute the recording.
Yeah, no problem.
Maybe some other notes that come out of this, and if we, when they become available, we will distribute them to everybody. But just want to say thank you again. It's always really, really interesting. A lot of thank yous coming through. I hope I haven't missed any questions. Good session, very informative. Lots of thank yous coming through. So thank you again, Robert. Thanks everybody for attending, and look forward to seeing you again next time.
Thanks.
Thanks, Mark. Thanks, everybody, and good luck.
Thanks, Robert.
We'll need it. Cheers, Mark. Yeah.
Bye.
Bye.